Muy buen día a todos. Nuevamente, el día de hoy contamos con el privilegio de tener a un gran invitado con nosotros, que es el doctor Jean-Baptiste Lepichon. Vamos a continuar en inglés. Dr. Jean-Baptiste Lepichon joins us from the Children's Hospital of Kansas. He is a pediatric neurologist, director of the Child Neurology Residency Program, and program director of neuroscience research. He is also a professor of pediatrics at the University of Missouri in the Kansas City School of Medicine, also a clinical assistant professor of neurology in the University of Kansas School of Medicine. And today, he will be imparting us with the topic, Evaluation of Neurodevelopment in Newborns. Dr. Lepichon, we are honored to have you with us once again.
Good morning, and thank you for inviting me for this second talk. And Deborah, thank you for this very generous introduction. So again, I will apologize again today for not speaking Spanish. I've been working on it, but I'm not making much progress. So today the topic will be evaluation of the neurodevelopmental of the newborn. We're going to focus on congenital hypotonia. And everything I'm going to present today is largely based on two sources. One of them is a book chapter that Dr. Shapiro, who presented to you yesterday, and myself wrote a few years ago in this textbook of neonatology. And the second is from a paper that is in preparation that I've been working on with my former resident, Dr. Sonal Sharma, who is now at CHOP, the Children's Hospital of Philadelphia. So I'll be presenting you this work. So we're going to focus again on hypotonia this morning. And the evaluation of the hypotonic infant is one of the most difficult things that a pediatrician or a child neurologist is brought to do. It has presented a challenge for all of the clinicians and is always a bit of a conundrum as to how to evaluate it. So in order to do this, there are a few basic concepts that need to be grasped. The first one is there is a fundamental difference between tone and strength. Tone is the ability to generate posture or resistance to passive movement. So it can be postural or truncal, and it can be phasic or peripheral. The truncal tone is your ability to sit in the chair and to not sort of slump or fall. And the phasic or the peripheral tone would be your ability to hold that cup of coffee without dropping it. Strength is the ability to generate movement. So strength is very different from tone. So hypotonia, by definition, would be the inability to generate posture, and weakness is the inability to generate movement. Once one has grasped those fundamental concepts, we can then move on in the evaluation of tone and in the infant. And this is from a landmark textbook, really, by Dr. Dubowitz on the floppy infant. It's an old textbook. It was published in 1980, but it is still very much, it has some very basic concepts that are still very much of use today. And so the traction response is the most sensitive measure of postural tone. An infant should pull back during traction and flexion, and you should see flexion at the elbows. It appears around 33 week of age, and at term, you should see a good response to traction. So you can see that all of these infants, which is from Dubowitz's textbook, have abnormal tone response. They don't have correct posture of the head and the trunk in response to this traction. Two other methods that people can use to evaluate tone are vertical and horizontal suspension. This is vertical suspension, again from Dubowitz's book, and this is horizontal suspension. So in vertical suspension, you place the infant you grab the infant under the axilla, as you can see here, and the child should basically hold without falling. So you shouldn't have to do a whole lot of grasping of the thorax because the tone that is holding the shoulder girdle in place should basically hold that child within your hand without you having to grasp him. If they slip, as is the case in all of these children, you can see that they slip in between the examiner's hand and the tone in the shoulder girdle is not enough to keep them there, then they have hypotonia. In horizontal suspension, the normal infant will maintain the head back and straight and all of the extremities flexed. The hypotonic infant, as opposed to the normal infant, will drape around your hand. And so these are all abnormal horizontal tone. So what are the causes of congenital hypotonia? Well, there are many. They can be basically broken down into two groups: central hypotonia and peripheral hypotonia. Now that's a bit of an artificial difference in that some disorders will really be at the borders in between those disorders. So for example, spinal muscular atrophy involves the motor neurons in the anterior horn of the spinal cord, but it also involves the peripheral nerve that will be dying. Severe hypoxic ischemic encephalopathy can actually involve both the brain and the spinal cord. So it's important to recognize that these divisions are useful but artificial, and that not everything always fits nicely in one of those categories. So what is the etiology of congenital hypotonia? This is probably one of the most important slides of today's presentation. And that is that anywhere from 66 to 88%, so basically 3/4 of congenital hypotonia is central in nature. In other words, something is wrong with the brain. And the vast majority of these are going to be caused by hypoxic ischemic encephalopathy or intracerebral hemorrhage, or chromosomal abnormalities and syndromic disorders. So if you look at this figure, this is all of the causes of hypotonia, and you can see that central hypotonia accounts for nearly 2/3 to 3/4 of all of the causes. Then peripheral hypotonia, depending on the sources that you read, will account for anywhere from 10 to 35, or so, a third of the causes. Now, if you take the causes of central hypotonia and break them down, as we just discussed, hypoxic ischemic encephalopathy or intracerebral hemorrhage will account for about 1/3 of the cases, whereas syndromic or chromosomal will account for about 1/4 of the cases, and then brain malformation will account for 10% and metabolic disorder for about 8%. So what about localizing the hypotonia? We've been talking about central hypotonia versus peripheral hypotonia. Is it possible to make the difference? Well, yes, there are some clues that can be very helpful. I cannot emphasize enough the importance of the history of present illness. So the history will give huge clues. If it's a premature infant, it's much more likely to have hypoxic ischemic encephalopathy, and what was the prenatal history, and then the birth history. Is there a history of perinatal asphyxia? So those are just some very basic examples that illustrate how the history is fundamental to this. And then the exam, in central hypotonia, the exam will typically show no weakness, but it will show low tone and variable reflexes. So early with central hypotonia, the children will be hyporeflexic, and late in the process of the injury, they will become hyperreflexic, which is typically what you will see with the children with cerebral palsy, spastic quadriplegia. They're very hyperreflexic, and in fact will go on to develop clonus. In peripheral hypotonia, they're typically both weak and they have low tone. Your ability to detect reflexes is going to be compromised by the weakness. And so you might be able to detect reflexes, but if you're not able to detect reflexes, it may actually be related to the tone. So that actually varies. But in peripheral, the big difference between peripheral and central hypotonia is whether there is weakness or not. And we're going to see some examples of this. So, central hypotonia. Again, it is the most common cause of hypotonia in infants. We just discussed the fact that it accounts for about 2/3 to 3/4 of all causes of congenital hypotonia. It is frequently, so some clues to central hypotonia. If there is decreased consciousness, that's a major clue that something is wrong with the brain. If there are seizures, again, that's another major clue that something is wrong with the brain and points you in the direction of central hypotonia. Dysmorphic features will often point you in the direction of a central hypotonia. So, for example, if it's a child with Fukuyama or Walker-Warburg disorder, you will see some dysmorphic features that will point you in the right direction. And I'm sorry, hypotonia with upper motor neuroscience, such as fisting. Now, this will typically occur later, but fisting or scissoring or an exaggerated moro or an obligatory tonic neck reflex are always abnormal. Those are always things to look for. Of course, this is following extinction. So, the most common cause of central hypotonia, I think I've harped on this quite a bit already. It is hypoxic ischemic encephalopathy. And in this case, the MRI is your best tool. So this will be especially common in infants who had a difficult delivery or who were premature. The premature infant, as opposed to the infant showed in this MRI, is going to develop periventricular leukomalacia, which I have not shown. The term infant will tend to develop more this pattern of injury. It'll actually vary depending on the severity and the length of the hypotonia. You can see that this child on the ADC has some thalamic changes and some changes in the occipital region, as shown in the hypodense regions here in the occipital regions. And then on the DWI, you will see these hyperintense regions that will correspond to the injury. So this would be probably a moderate to severe hypoxic ischemic injury in a full-term newborn. You can also assess the fact that it's a full-term newborn by just looking at the maturity of the brain, and this is very normal for a full term. So this was an example of central hypotonia. This is an example of peripheral hypotonia. Although, again, as I stated earlier, the distinction between central and peripheral hypotonia can be a little bit artificial, and this is a good case where you have death of the anterior motor neurons. So this actually is an injury that occurs in the cord. So technically, that would be part of the central nervous system. But it is the peripheral neuron that dies. So the spinal muscular atrophy type 1, there are 4 types of spinal muscular atrophy. If one counts the type 0, but the type 1, which is the most common, which most of us are familiar with, is also known as Werdnig-Hoffmann disease. It is caused by deletion of this survival motor neuron 1. In fact, it is not quite deletion of the survival motor neuron 1. It is deletion of exon 7 of the survival motor neuron 1 gene in most cases, in the vast majority of the cases. And the deletion of this exon 7 results in a protein that is dysfunctional. And as a result, the neurons die. Now, we have developed a little trick over the course of evolution in that we have a defective copy of the survival motor neuron gene, which is called survival motor neuron 2, and sits in tandem, actually head to head or tail to tail, if you wish, with survival motor neuron 1. And this, we can have variable number of copies. This copy of the survival motor neuron is actually missing exon 7. And so it produces about 10% of the normal protein that survival motor neuron 1 gene normally would. But the result of that is if you have multiple copies of survival motor neuron 2, you can actually have a moderately normal or a much milder disease even if you're missing survival motor neuron 1. And that is illustrated in this spinal muscular atrophy type 2 and type 3, where the number of copies of survival motor neuron 2 compensate for the absence of survival motor neuron 1. What is important here is this is a diagnosis you should not miss for several reasons. The first one is it is a catastrophic disease. The infants, when they present with spinal muscular atrophy type 1, will have profound muscle weakness, weak cry, difficulty swallowing, tongue fasciculation, and difficulty feeding. They will have no reflexes. So if you can find reflexes, it is probably not SMA type 1. And the diagnosis is relatively cheap. It is done by either restriction fragment length polymorphism or by PCR of exon 7. The answer comes back very quickly, and so it should be sent rapidly, and these infants should not be ignored. So this is the classic presentation of an SMA type 1. I like to show this picture because it is so classic. You can see this child has a very abnormal posture. So this child's tone and it is very, very abnormal. It does not have the normal flexed position that you would expect of a newborn infant. But what is quite remarkable is if you look at his face, he has this really alert look, and this is very typical of these children. Their brain are intact, and they will typically have this very alert look. And why this is the second reason for which this is important is we actually have 2 treatments now for spinal muscular atrophy, and both are curative to an extent. The first one is Speranza. Speranza works by binding to a sequence upstream of the exon 7 in survival motor neuron 2. And what that does is it prevents exon 7 from being spliced out. So a full-length mRNA is produced, and it produces a functional protein. Now, this is a great treatment. It actually rescues the phenotype of the normal infant. The problem is the injection are intrathecal and they need to occur on a regular basis. And it is quite expensive. The drug itself, I think, is $125,000 per injection in the United States. Prices tend to be quite inflated in the United States. But there is a second treatment for SMA, and that is gene therapy, true gene therapy now. So Novartis created this therapy, which is what they did is they used a modified adenovirus 9. They removed the viral DNA. They replaced it with the survival motor neuron 1, and they do just one intravenous injection, and it is a cure. These children are cured. So this is quite important. The cost in the United States is $2.1 million per injection. Now, that being said, Novartis invested $8.7 billion in this. So I think what I leave you with is no answer as to whether this is right or wrong, but maybe sort of a reflection as to how we should price these medications and how we should distribute them. So moving on, we get toward the second part of this talk, which is going to focus on the work that Dr. Sharma and I have been doing over the last few years. And so this is the traditional approach to congenital hypotonia. I realize that this is a figure that is very difficult to read, but this is extracted from a paper that is several years old now, that basically goes through all of the steps that are typically done in congenital hypotonia. So you start with a localized history and a physical exam. You obtain a karyotype and a FISH, and you move on to biochemical studies. These often include serum and cerebrospinal fluid. Then you do EEG, nerve conduction study, and EMG, and maybe you'll even do a biopsy. And finally, at the very end, you get to targeted genetic testing. So Dr. Sharma, who was my resident, just graduated in June of this year, is now moved on to the University of Pennsylvania in Philadelphia, did a retrospective study where she looked at 496 infants who were seen in our hospital over a 5-year period. And they all had a diagnosis of congenital hypotonia. So we had the benefit of our research center and our genome center, where we are pretty proactive in terms of getting a lot of exome sequencing. And so the result are we actually started out with 496 patients. 172 of these did not have any genetic testing, so they had to be excluded. So we were left with 324 patients who met the inclusion criteria. And you can see from the demographics that they were pretty well distributed among males and female. The 65% of them had central, what we would call diffuse, probably central hypotonia. 28% had axial and peripheral hypotonia, so more consistent with peripheral hypotonia, which reflects very well what we had expected. And in terms of the clinical symptoms that we collected, you can see here the spread of the clinical symptoms, and they're pretty much what we expected. So of all of those patients, about 148 had a karyotype, 247 had a microarray, 136 targeted sequencing, 39 had a gene panel, 134 had a whole exome, and 6 had a whole genome. And you can see that the diagnostic yields were actually pretty good. There were 39%, 32% for the karyotype, 19% for the microarray, 30% for targeted testing, etc. So moving on to the result here, what was really interesting is that there was a substantial concordance between the karyotype and the microarray. So if you look at all of the microarrays that were positive with a negative karyotype, so there were 10 that were picked up by karyotype and missed by by microarray and missed by karyotype. But there were, the convert of that is that there was only one patient who was picked up by karyotype and missed by microarray. So, so we conclude from that that actually the karyotype in the vast majority of cases, the microarray in the vast majority of cases is going to be sufficient, and you will not need a karyotype. We then did a stepwise logistic regression model, and we were able to show that dysmorphism is really the only clinical feature that increases your yield in terms of obtaining a karyotype. Epilepsy actually lowered the yield, and that probably has a lot to do with the fact that many of these children with epilepsy had hypoxic ischemic encephalopathy. In the MRI findings, no MRI abnormality was associated with a positive yield of the genetic test, meaning that you do not get an MRI. This was a bit of a surprise to us. We even looked at abnormalities such as, what would have been migrational abnormalities, and we could not find a positive yield. The metabolic testing, this is important. 209 patients had metabolic testing. 65% of that's 65% of all of the patients, and of those, only 7 had a positive diagnosis. And of those 7, the 4 who had next generation sequencing were all confirmed by next generation sequencing. So our conclusion from that is that metabolic testing is probably unnecessary for the vast majority of patients. Metabolic testing will include things like urine organic acids, plasma amino acids, acyl carnitine profile, et cetera, et cetera. Now, of those who had a positive result from their gene testing, as a result of the positive testing, 98% started receiving a combination of physical therapy, occupational therapy, or speech therapy. 91% of the families received genetic counseling, and 10 patients, 6%, received a disease-altering drug. Which is, if you think about it, would not have happened had we not been able to do the testing. So this is our new suggested approach to congenital hypotonia. So the infant who presents with hypotonia, there's really 3 scenarios that can happen. The first one is there's obvious dysmorphic features that suggest a chromosomopathy, so an abnormal chromosomal count. Trisomy 21, trisomy 18, trisomy 13. For those patients, a karyotype is very reasonable, indicated it returns very quickly, it's relatively cheap. Then there is the patients who present with specific clinical features that are reminiscent of a specific syndrome. So for example, spinal muscular atrophy, or myotonic dystrophy, or Prader-Willi syndrome, or Fragile X. And in those cases where the disease is clearly recognizable, then the specific test for that disease should be sent. For all others, which is the vast majority of the patients, we would recommend that actually starting with a microarray, and if the microarray is negative, moving on to whole exome sequencing, and karyotype is probably not needed. So in conclusion, congenital hypotonia remains a challenging diagnosis. The history and the physical are still essential. MRI is still first line in clear cases of hypoxic ischemic encephalopathy. Karyotype and targeted testing should only be used for recognizable disorders. Metabolic testing has very low yield and can be foregone for the vast majority of time. And microarray followed by whole exome sequencing should probably be first line in ambiguous cases, which is the vast majority of the cases. And that is the end of the talk for today. I'm happy to take questions if there are any.